Hello, everyone. Shall we get started? I am Jennifer Ingleby. I am the Deputy Director at the Center for Women's Health Research. Welcome to Let's Talk, Conversations about Women's Health. Let's Talk is a lecture series created by the Center for Women's Health Research along with UCHealth, and we are very thankful for their partnership in something that has been going on for 9 years now. This is our 9th year for the Let's Talk lecture series, and we're thrilled to have you all. Thank you for that, too. Women and men can present with different symptoms, respond differently to medications and treatments, and receive different care. The Center for Women's Health Research is committed to a future in which research includes women and men and accounts for sex and gender differences. We do this to shape better health care for all. And we do this through research, by mentoring and training the next generation of researchers, and through educational events like this one today. Tonight, as in most Februaries, we focus our Let's Talk on heart health. Cardiovascular disease is the #1 killer in both men and women. And tonight we have an amazing lineup. We have Dr. Peter Buttrick, head of our Division of Cardiology, Dr. Judy Regensteiner, director and co-founder of the Center for Women's Health Research, and Dr. Robert Page, professor in the School of Pharmacy. Following their talks today, we will have a panel and Q&A session, and I hope you all can stay for the full session. A little housekeeping, please turn off your cell phones. And at the end of the talk, we'll remind you once again that we do send out a survey at the end of the talk, and that's really how we do get ideas for these talks. So please take a moment to do the survey. And also, we're happy to announce that our next Let's Talk will be on April 23rd. So please mark that in your calendars, and it will be on, it's All in Your Head, the Importance of Brain Health. So with that, I will introduce our first speaker. We were honored to have Dr. Peter Buttrick a few years ago at this similar talk, and we are thrilled to have him here once again. Dr. Peter Buttrick is the head of the Division of Cardiology and the S. Gilbert Blount Endowed Chair at the University of Colorado School of Medicine. He also serves as a Senior Associate Dean for Academic Affairs and is the co-director of the Cardiovascular Institute at the University of Colorado. He is the Associate Editor of the Journal of Health Failure and has been a member of the editorial boards of the Journal of Applied Physiology, the American Journal of Physiology and Heart and Circulatory Physiology, and the Journal of Molecular Cellular Cardiology. He serves on multiple National Institutes of Health peer review panels, and Dr. Buttrick has published more than 150 peer-reviewed and solicited articles. Is the recent recipient of numerous grants for his ongoing research in integrated mechanisms of cardiac maladaptation and myofilament function in the heart failure. He is a member of the Association of American Physicians and Association of University Cardiologists. Please welcome Dr. Peter Buttrick.
Thank you very much for that gracious introduction. I don't feel as distinguished as I was introduced. It's a pleasure to talk to you, and I want to thank Judy for the invitation. When she asked me to talk, she gave me very little guidance as to what to talk about. She said, talk about women and heart disease, which is sort of an all-encompassing topic. So we're going to meander through myths, misconceptions, mostly around heart attacks in women, and a little bit about how misperceptions by patients and doctors and the research community need to be readjusted. It's an educational talk that you should take forward, educate your friends, your doctors, and the institutions that they work in. To begin, I think it should be self-evident that cardiovascular disease is the leading cause of death in women. More women than men die of heart disease each year, and more women die of heart disease than the next 7 causes of death combined. Those are sobering statistics, but they're probably more sobering because most people don't appreciate the severity of the problem. If you were to pool a group of women or men, or frankly, family practitioners, as we're going to come to in a few minutes, and were to ask them what are the leading causes of death in women, they probably would not all say heart disease. A large percentage would say cancer. And in fact, I just want this slide to be illustrative of the fact that heart disease really is, insofar as both women and men are concerned, the leading cause of death, and annually more women than men die of heart disease in the United States. The trends are not altogether favorable. If you look historically, women are in the red line, men are in the blue line, and you can see as a profession we're doing okay at reducing cardiovascular mortality in men, but we're not doing so well in women. And I'm going to touch upon some of the reasons why this might be the case and send you forth with the charge to try to fix this problem. And the question that I would ask at the beginning and ask you to answer at the end is how come we're doing so well in women and not so well in men? How come we're doing so well in men but not so well in women? As an aside, let me just interject this. When we talk about heart attacks, we generally talk about a fairly consistent pathophysiology. A coronary artery gets blocked and myocardial damage ensues. There are a couple of unusual phenomena which occur largely in women and almost never in men. And I thought I would at least introduce them at the outset because probably you'll cross paths with these diagnoses at some point. On the upper left is an unusual disease that's called Takotsubo cardiomyopathy or stress cardiomyopathy. It was first described in Japan in the aftermath of Hiroshima, and it turns out a number of people that survived that blast had hearts that were badly damaged. And when you looked at their coronary arteries, they didn't have coronary artery disease. They'd sustained what we currently refer to as stress cardiomyopathy. Takotsubo is kind of a cute name, which was applied to this phenomena about 20 years ago, so many years after the phenomena was first described. And a Takotsubo in Japan, I didn't know this, is a ceramic pot that you use to catch, I believe, octopuses. They swim in and they get stuck because the neck is narrow and can't swim out. And the heart that has sustained an insult as a result of stress cardiomyopathy looks the same, which is to say it bulges at the apex and is narrow at the neck, and that's illustrated in the adjacent picture. This phenomena occurs almost exclusively in women, about 75% of the time. Why, I can't tell you. But one of the reasons why the mortality figure in women remains high is because this is a different kettle of fish. The other different kettle of fish is in the bottom right, and this is a phenomena called spontaneous coronary artery dissection. Again, the etiology of this is, relatively speaking, obscure, but it occurs, again, almost exclusively in women, often in the context of pregnancy or just following delivery. And what happens is the coronary artery spontaneously tears. The tear, you can see the outline of the tear where this yellow is about to show up. And it's an absolutely devastating phenomena in young women. About a quarter of women under the age of 50 who have heart attacks, this is the etiology, and it's an unconventional etiology. With that as an aside, I want to focus more on conventional disease, which is to say coronary artery disease. And I would like to at least propose that one of the problems that has afflicted our ability to treat women is perceptual. The second problem is biologic. Women are not small men. But from a perceptual standpoint, it's actually surprising to me that although we begin this conversation today with an understanding that heart disease is a big deal in women, the percentage of women that are aware that coronary heart disease is a leading cause of death in women is not nearly as high as you would hope it to be. This is a graph which shows that in 2009, only about half of the women surveyed knew this. Just for what it's worth, if you do surveys online, the percentage that are aware of this a little bit higher. Maybe that speaks to the fact that people who are online are Googling heart disease more frequently than the rest of the public. And if you look at racial stereotypes, white women know this piece of information more than Hispanic, African Americans, and Asian women. And it suggests that we have cultural problems as well as overall perceptual problems in addressing the fact that this disease is highly prevalent and not nearly as well recognized as it should be. Interestingly, women and men perceive cardiac symptoms. They perceive that they're having a heart attack somewhat differently. This is actually interesting because it's been written in the literature for 30 years that women don't get chest pain when they have heart attacks. The study that's referenced here is one that was done in Europe about 4 or 5 years ago, where individuals who had survived a heart attack were asked in detail about what symptoms they had that heralded that heart attack. And surprisingly, chest pain or chest pressure was appreciated in 85% of women and 87% of men. So that's pretty common as a perception and pretty consistent across the genders. Women were far more likely to report referred symptoms, so the chest pain radiated to different parts of their body. They were also far more common to report associated symptoms like palpitations, restlessness, or nausea than were men. Sort of interesting, and I can't give you a biological explanation as to why that's the case. But strikingly, women were far less likely than men to associate even classical anginal-like chest pains with a coronary event than were men. Women felt they were having a heart attack, and they were, only about 40% of the time, whereas men felt they were having a heart attack about 65% of the time, even though the symptoms were probably really quite similar. So we have a perceptual problem that we have to get past. To continue on the theme of misperceptions, these are data that I'm showing partly because they're amusing and partly because they're illustrative. These were surveys that were done in 2 points of time about what were reasonable prevention strategies to target coronary disease. The 2 points in time were 1997 and 2009. I've taken off of this table the things that I think are pretty well understood, which is taking statins, exercising. But you can see that a variety of things which I would say would not be mainstream therapies were felt to have benefit. So in 1997, about half of the women surveyed felt that hormonal therapy was a good idea. It actually isn't. It's probably a bad idea. And in 2009, that misperception had been corrected. Perceptions about aromatherapy, however, have gotten somewhat worse. I don't know the literature that supports this, but apparently 30% of the people surveyed really were enthusiastic about aromatherapy. And reading up to the top, you can see other things which I think are not necessarily mainstream, got a lot of credence. Multivitamins, preventing gum disease. I don't want to diminish praying and meditating, but they're not mainstream therapies for coronary disease. And yet 74% of individuals surveyed were all on board with that. The things closer to the top, I think one can probably justify. Sleep is a good idea. Fish oil and omega-3, there was just recently a study that came out just within the last couple of years that was very enthusiastic about this. Aspirin comes and goes with each decade. Currently, we're down on aspirin, but if you were to ask me 10 years ago, I would have been all in favor of aspirin. And fiber, I'm sort of agnostic about. But you can see that perceptions and misperceptions haunt the literature that's online and haunt the subconscious of many patients. So other pieces of information that I think are relevant to this question of misperception. In 2009, women were surveyed as to whether or not they had discussed heart disease with their primary care physician. Now remember, heart disease is the leading cause of death by far in women, and yet only 48% of women had even had a discussion about heart disease with their physician. So I'm going to encourage all of you to go forth, call up your physician and say, how come we haven't talked about my heart? Because you should. Insofar as MI symptom recognition was concerned, about half of the women surveyed in this particular study recognized that chest, neck, and arm pain could be associated with a heart attack, 29% shortness of breath, 15% nausea, and that's it's correct for those patients, but it's a relatively small percentage of the total, and that number didn't change over the intervening decade. 53% of women would call 911 if they thought they had symptoms that might reflect a heart attack, but half of the women wouldn't. And again, I think we're dealing with misperceptions that we should work hard as a profession, as a community, to try to correct. So perceptual problems aren't just on the part of the patient. Perceptual problems also, I'm sorry to say, bedevil my profession. This was a study that was done in 2006, so a decade or so ago, and to my knowledge has not been repeated, but it's sort of damning. More than 90% of primary care physicians didn't know that heart disease annually kills more women than men. And here's a study that was done a couple years after that. It was for primary care physicians. A clinical scenario, this was a thought experiment, was presented to primary care physicians, and it was sort of an abstract clinical scenario. You're presented with a 50-year-old person who presents with atypical chest pain and some shortness of breath. There's a family history of heart disease. Something that was fairly nondescript. If you, this same scenario, if you didn't say if the subject, the patient, was a male or a female, 50% of the physicians surveyed thought a cardiac diagnosis was likely. If you introduced gender into the scenario and just said, rather than a 50-year-old person, you said a 50-year-old man or a 50-year-old woman, the primary care physicians, if you said man, felt 60% likelihood that it was a heart problem, and only 30% of the time if a woman was the subject. So not really a ringing endorsement of the diagnostic acumen of primary care physicians. And if you introduce stress, and by stress I mean the chest pain occurred during a moment of anxiety, exertion, fight, when you introduce the concept of stress, for reasons that one can only speculate, that made the primary care physicians think that it was even less likely that the women were presenting with a cardiac diagnosis. So again, I would encourage you to go forth, slap your primary care physician around, and tell him that heart disease is a real thing, and that it should be discussed in more detail. So what these perceptions have actually some implications. Some of them I think are amusing. Prayer or aromatherapy as therapy, I think that's interesting to mull about where that comes from. But the misperceptions that I've talked about, both on the part of the patient and on the physician, have resulted in a number of sad truths. Women with heart disease and heart failure are less likely than men to be referred to a hospital, less likely to be referred to a teaching hospital, less likely to be managed by a cardiologist, less likely to have coronary angiography, exercise testing, or EKG monitoring, less likely to be treated with medications that we regard as evidence-based, and they experience less improvement a year after a hospitalization for heart failure. So these misperceptions, I would argue, at least contribute to the fact that women are not getting the care that they actually deserve. Now, perceptual issues can be corrected, and in academic medicine, we like to say that we look for evidence to back up our medical decision-making. But we have a problem, which is that women are very, very much under-enrolled in seminal clinical trials. This is a list of trials that didn't address coronary disease but spoke to congestive heart failure, and they were trials that used one or another drug as a treatment strategy. That's a lot of trials, and as you can see, not a lot of women. The average number of women that were enrolled in these trials should have been 50%, and in fact it was about 18 or 19%. There are reasons for this. Women often are a little bit older when they're asked to enter clinical trials. There are often comorbidities which preclude their enrollment in clinical trials, but I still think this is indefensible. And if we're going to make judgments, Robert's going to talk about pharmacotherapy after I finish. If we're going to make judgments about what therapies are most appropriate for which gender, we better be studying this in an appropriate fashion. I think the profession is doing a little bit better, but we could do a lot better. So this just mentions some of the reasons why women are not included, but I actually don't think it's a compelling defense. So what we've talked about are a lot of perceptual problems, and I think I will give credit to the American Heart Association, that the American Heart Association is working really hard to correct some of these perceptual problems. There are a lot of red events that occur this time of year. If you go online, you can see a large number of pictures of women wearing red dresses that are participating in Heart Health Month and are participating in activities that are supported by the American Heart Association. And in fact, we're doing a pretty good job of actually doing some branding, including Diet Coke. I might prefer that we branded something else, but it's at least a step in the right direction. But I think the point that there needs to be a lot of education around women and heart disease has been recognized by the Heart Association. And I still think we have, as the data that I've shown you indicates, I think we still have a ways to go. Now, I want to shift gears. I've now talked a little bit about perceptual problems, both on the part of patients and physicians. There are also some biological truisms. As I said before, a woman is not a small man, and heart disease actually is different in women than it is in men. And understanding the biological differences that drive cardiac maladaptation is very, very important, and there's no shortcut. We have to do this hard work. I'll summarize some of the things that we know, and these are basically physiologic differences when you compare women and men's hearts. Women have smaller hearts. They tend to be smaller people, but they also have smaller coronary arteries, smaller cardiac muscle fibers. Their coronary arteries are more subject to vasospasm. Women have higher resting heart rates, and if you look at how much blood is ejected from their heart with each beat, that percentage tends to be higher in women than in men. However, when women exercise, the amount of blood that's ejected with each beat doesn't increase to the same degree as it does in men, and some of the electrical properties of women's hearts are different than men. These are biological properties. So this is the way women's hearts are built. In response to a pathologic load, which is to say high blood pressure, aortic stenosis, and studies have been done across the phylogenetic spectrum, from mice to rats to intermediate-sized animals to people. The biological responses of the hearts of females are different than the hearts of men, and this just summarizes some of the findings. If you expose a rat, and I have to confess I have done this, to hypertension, the hearts of female rats hypertrophy, they get thicker by about 45%. The hearts of male rats don't get nearly as thick, so there's a different biological response. If you look across the age spectrum, women have higher age-adjusted rates of left ventricular hypertrophy, that's muscle mass, at all levels of blood pressure. So the phenomena described in rats is absolutely translatable in people. In response to severe aortic stenosis, women's hearts tend to get thicker, whereas men's hearts tends to dilate. And if you look at adults with clinically evident heart failure, left ventricular dysfunction is more common in men than in women. These are all consistent responses, and they speak to the fact that the hearts of women are different at baseline, and they also respond to pathologic stresses different. And in order to understand therapeutic strategies to treat diseases in women, we need to understand the biological basis for these differences. The good news is that women who have heart failure tend to live longer than men who have heart failure. These are data which date back to the Framingham Heart Study, which I personally feel was the most seminal clinical study done in the 20th century. And you can see that almost regardless of etiology, the women on the right tend to live longer after the diagnosis of heart failure is made than the men. So that's a nice piece of news. Now, to get to this question of biologic difference, we have to be fairly nuanced in trying to figure out what drives this. So my colleague Leslie Leinwan in Boulder has been very interested in the changes in gene expression, expression of different genes which are resident within the DNA of male and female animals. And as you can see, there are a lot of differences. At 2 months of age, which is relatively young if you're a rodent, even younger if you're a person, there's about 39 genes which are differentially expressed just as a function of gender. And as the animals age till they reach what is essentially adulthood, almost 120 genes have very different patterns of expression. So biologically, the things that happen, irrespective of any external stress, distinguish males and females. Now, Leslie's looked at what these genes are, and this at least indicates that they affect a variety of different properties of the cardiac myocyte. About half of them we don't know what they do. Hopefully we'll learn. About a quarter of them affect the ability of the heart to metabolize substrate, and the balance affect all sorts of stuff. But the point that I want you to at least mull over is that biologically, the hearts of males and females are actually biologically different. Now this translates, and Robert's going to talk about this more, into how does a male heart in a man and a female heart in a woman respond to pharmacotherapy. So we have a couple of different therapies that we regard as evidence-based, for example, for heart failure. One of those therapies is a beta blocker therapy, and these are drugs like metoprolol, propranolol, and this is a series of studies which actually looked both at males and females to try to figure out if men and women responded with heart failure, responded equivalently. And in the case of beta blocker therapy, the answer is absolutely yes. You can see that if you look at the risk analysis on the right, both males and females in every clinical study did better with beta blocker therapy than those that were not treated with beta blocker therapy. So there was no distinction here. In contrast, another drug that we use for heart failure is a category of drugs called angiotensin-converting enzyme inhibitors. And when you look at how these data break out, that the answer is actually somewhat different. These are 4 clinical trials that looked at this class of drugs as a treatment for patients with heart failure. And as you can see, and I'll read through this, in the consensus trial, there was a highly significant statistical reduction in mortality in men, but there was no statistical reduction in mortality in women. In the solved trial, similar trial, using a similar drug, similar result. Men experienced a reduction in mortality and hospitalizations that was greater than the reduction seen in women. In the SAVE trial, a slightly different etiology of heart failure, there was a 2% mortality risk reduction in women. That's not insignificant, but it pales by comparison to the 22% risk reduction that was seen in men. And the same type of data were seen in the TRACE study. So I think when you think about the biological differences between male and female hearts, these have real implications for what therapies are and are not appropriate. And in fact, the inability to enroll women in clinical trials in the numbers that are necessary to draw meaningful conclusions hampers our ability to make rational biologic decisions. So let me summarize, because I'm supposed to stop at around 6:30. At the end of the day, I think heart disease in men and women is viewed differently. It's viewed differently both by patients and by providers, and this is despite substantial educational efforts. So I would urge you to go forth and educate everybody you know and tell them that there are misperceptions that are rampant in the community, and healthcare begins, one person at a time. I think that the differences can be perceived as reflecting perceptual bias, but also reflecting real biology. As I pointed out, the unstressed hearts of men and women differ in really fundamental ways. So heart failure in women also differs, and the treatment effects on mortality, I think, still are unclear, and I think we do not tailor therapy in a gender-specific fashion. We tailor therapy in a disease-specific fashion, and that's probably short-sighted on the part of our profession. I can't explain all of these biological differences to you. I can tell you that they exist, and they really need to be analyzed further. So what do we do about this? Well, I'm a big believer in data. I think animal studies allow us to make a controlled assessment of sex differences in muscle physiology, and I think animal studies have been shown to effectively mirror the clinical situation and will help elucidate pathophysiologic basis of these sex differences. I think shame on us as a profession for not doing better at enrolling women in clinical trials, and I will say the NIH now is fairly aggressive about looking at clinical trial design to make sure that there is appropriate representation of men and women. But I think finally, what we all need to do is recalibrate our perceptions and to help recalibrate the perceptions of the communities that we inhabit. I think I'll conclude there, and thank you very much.
Wasn't that amazing? Thank you, Dr. Buttrick. Our next speaker, for many of you here and who have been coming to Let's Talk for a while, probably needs no introduction. But I'm going to introduce her or reintroduce her to many of you here tonight. Judy, Dr. Regensteiner, has done this introduction for most of our Let's Talks over the last 9 years. So I am very honored to introduce our center director and the co-founder of the Center for Women's Health Research. Dr. Judy Regensteiner is the director and co-founder of the Center for Women's Health Research and professor of medicine in the divisions of internal medicine and cardiology at the University of Colorado Anschutz Medical Campus. She holds the Judith and Joseph Wagner Chair in Women's Health Research. Dr. Regensteiner's research expertise is in the cardiovascular effects of diabetes, with a specific focus on women with type 2 diabetes. Her lab has been funded for over 20 years, and she has authored more than 150 recent publications. Appointed by the U.S. Secretary of Health and Human Services, she served on the Advisory Committee for Physical Activity Guidelines for Americans. She currently serves on the National Institute of Health's Advisory Committee on Research on Women's Health and the Steering Committee on the Leaders Empowering the Advancement of Research and Women's Leaders Empowering the Advancement of Diversity in Education, Research, and Science. The acronym is LEADERS. As co-founder and director of the Center for Women's Health Research, which includes this Let's Talk lecture series, Dr. Regensteiner leads an interdisciplinary team of researchers who focus on women's health and sex differences research. Welcome again, Dr. Regensteiner.
Thank you for the lovely introduction, Jennifer. Thank you all for coming tonight, and to our guests, Dr. Page and Dr. Buttrick. It's really great to have you here. So the bottom line take-home message tonight is that the most important way to prevent cardiovascular disease is to promote a healthy lifestyle throughout life and to treat risk factors, if you have any, by the guidelines. I'm going to focus tonight on a talk on primary prevention, which means preventing heart disease. If you already have heart disease, it's also important that you treat your risk factors, but the rules are just a little bit different. In terms of sex differences in cardiovascular disease, we always have the question of what is biological versus what is disparity. Dr. Buttrick really touched on that. What do we know that's really biologically different between men and women, and what is it in the way women are treated, perhaps by their doctors, that is different, which can lead to different outcomes? We do know that cardiovascular disease, again, is a leading cause of death in women and in men, but it also causes a lot of disability in both men and women. And we also know, interestingly, that diabetes and smoking are more strongly associated with developing cardiovascular disease in women than in men. There's a higher prevalence of avoidable risk factors in women, including elevated cholesterol, decreased physical inactivity, and decreased overweight. It's more of a problem in women than in men. A lower HDL level, the good cholesterol level, is more predictive of cardiovascular disease in women than in men. Women also, though, receive less counseling about nutrition, exercise, and weight control. So again, it's always interesting. What's biology and what's disparity in the way women are treated? And again, I won't reiterate what Dr. Buttrick eloquently said, but only 8% of women identify cardiovascular disease as their greatest health threat. This is kind of scary, and it's really still true. It's kind of shocking, not just for patients again, but also for their physicians. Women get less treatment of cardiovascular risk factors. They get fewer referrals to cardiologists and are more likely to have symptoms ascribed to psychiatric causes, yes, still now. And they get a lower referral rate for diagnostic and revascularization procedures. So this is kind of scary. This is the algorithm from the American Heart Association, American College of Cardiology. I'm not going to spend any time on this algorithm because it's kind of scary just to look at it. So we're going to move right on. And I mean, if you want me to go through it later, we can do that, but not tonight. It's hard to read, even for me as well. So there are traditional risk factors for cardiovascular disease, most of which you've probably heard of. This includes the menopause, at which point women have a higher risk. After the menopause, it's thought that prior to the menopause, women have a protection from cardiovascular disease, probably hormonally related, but that protection goes away with menopause. High blood pressure is a big risk factor in women. Diabetes, smoking, obesity, and inactivity. There are also some emerging new risk factors, such as having diabetes while pregnant is a risk factor, having getting less sleep is a risk factor, and there are a whole bunch of new risk factors that are emerging, and I'm sure that it will come out with guidelines to help guide you through those as well, but not so much so far. Lack of sleep is a very interesting emerging risk factor. It's still an area which we need to know more, but it's now thought that you need to get roughly around 7 hours a night to have, it helps with your cardiovascular health. And the problem, of course, is that guess who has more trouble with sleeping? It is women. So women have more trouble sleeping, they get less sleep, and then they're more prone to cardiovascular disease. So we need to learn a lot more about sleep and cardiovascular disease. And interestingly, people like to talk about the preventability of heart disease. It's a very preventable disease in many ways, but there are some things you can't prevent, and those include your genetics, your age, and menopause. You can treat menopause, although the hormonal story is not simple, and most people don't recommend hormones or female hormones for people in menopause, but you can't do much about your age. And if anyone out here knows how to do something about your age, tell us right now, and you please give the rest of the talk, and your genetics. So how you behave, how you treat the risk factors can have a very, very big impact. So what are the guidelines for preventing cardiovascular disease? And I'll tell you them, and then we'll talk about it at the question and answer period. In the United States, hypertension accounts for more cardiovascular deaths than any other modifiable risk factor. Stage 1 hypertension is defined as systolic, the upper number of 130 over the lower diastolic pressure of 80. And if it's over that, or it's considered stage 1 hypertension. And I will make my slides available because they have the guidelines printed out on them. These problems, the risk of hypertension is even higher in Blacks, Asians, and Hispanic Americans and increases dramatically with increasing age. These are the guidelines. This is normal blood pressure, and these were just changed. Just as soon as you learn about the guidelines, they change them and give you new things to think about. But the American Heart Association, American College of Cardiology, a couple of years ago came out with a statement stating that normal blood pressure is under 120 systolic and under 80 diastolic, so 120 over 80. And below that is good, 120 over 80 is fine. Above that is not good. You have hypertension. However, there's still a lot of discussion that needs to take place with your doctor about this, because if you simply just control blood pressure to certain numbers, you can create other side effects, such as dizziness and the propensity to fall, that can be also a risk. So it's not as simple as just knowing the numbers. It is important, though, that, for instance, you have a blood pressure of a systolic of 160, and you've had it for a while, and your doctor keeps telling you that he or she is going to watch that blood pressure. And I always wonder, what does that mean? What are you going to watch it do? It's probably not going to come down. If it keeps being 160 over a year, you probably, sooner than that, need to be treated and not just watched. And that's true for cholesterol, too. And people will tell me often, well, I'm going to lose weight, exercise more, my blood pressure will come down, my cholesterol will come down. And those things are true. But if the number's high enough, it's not going to come down. Your blood pressure is not going to get to a normal level. So I always think that having medications adds to your ability to fight bad risk factors like high blood pressure, which can kill you. So the fact that you try really hard and change your lifestyle and have better blood pressure, but it's still not at target, that's what medicines are for. So. The guidelines for the American Heart Association and American College of Cardiology are verbatim as follows. Non-pharmacological intervention is the preferred therapy for adults with elevated blood pressure and an appropriate first-line therapy for adults with stage 1 hypertension, which again is 130 over 80, who have an estimated 10-year cardiovascular risk of greater than 10%. And you talk to your doctor. There's a way to estimate your risk. And if you do this, it will really help your doctor and you together to partner in a discussion about how much treatment you may need. But knowing your overall risk is really important. With a higher risk, and you should assess the approach of lifestyle changes every 3 to 6 months, not every 3 to 6 years. So again, if your doctor keeps telling you that they're watching your numbers, be aware that those numbers aren't probably getting any better, and you better do something. With a higher risk of cardiovascular disease, pharmacological treatments should be used. And for those requiring pharmacological therapy, the American Heart Association says the target blood pressure should generally be 130 over 80. So there's some realism in here. You're not going to lower hugely elevated blood pressures to a very normal level easily. And it often takes work, and it often takes more than one drug. So it's a lot to think about. And it's very common. And it's more common in black males than white males, and in black females than white females. And this is a very understudied issue in both men and women, but particularly women are undertreated for high blood pressure. So really keep an eye on that. Tobacco use is a leading preventable cause of disease, disability, and death in the United States. And you may all be thinking that nobody smokes anymore, but you would be wrong. A lot of people still do smoke. Smoking, and not just smoking, but smokeless tobacco, and also most likely e-cigarettes, we just don't know much about them, but they're not safe. They're nicotine delivery systems, and they are not safe. I just say they're starting to find problems with them. They just haven't been out very long. But smoking and smokeless tobacco are greatly increase the risk for death, especially from cardiovascular disease. Even low levels of smoking increase the risk of heart attack, so there's not a dose reduction approach you can take. Reducing your amount of cigarettes is good, but there's no safe dose that we know, and nobody's ever going to test to find you the safe dose of cigarettes. So if you smoke, you got to quit. You don't know if 2 or 3 a day is safe. You just don't know. and there will not be that study. So the American Heart Association, American College of Cardiology say all adults should be assessed at every healthcare visit for tobacco use, and those who use tobacco should be assisted and strongly advised to quit. There's no equivocating here, you just have to quit. And there are ways that, even for free, that people can get help with that. Men still smoke more than women on average, but smoking by women causes 150% more deaths from heart disease than lung cancer. Women who smoke are 2 to 6 times more likely to suffer a heart attack than men, and the use of birth control pills greatly increases your risk. In addition, horrifyingly, smoking in teenage girls is on the rise, so smoking is still a problem, even as hard to believe as that is. High cholesterol levels are also a significant risk factor for cardiovascular disease. And normal levels, I'm not going to go into the levels for good cholesterol, bad cholesterol, and triglycerides as much, but below 200 milligrams per deciliter is a normal total cholesterol number. Statin therapy is first line, so the statins like simvastatin, atorvastatin, Zocor, and drugs of that type are first line treatment for primary prevention of cardiovascular disease in patients with elevated low density lipoprotein cholesterol, that's the bad cholesterol, over 190 milligrams per deciliter. It should also be used in people with diabetes who are 40 to 75 years old of age, and those determined to be at sufficient cardiovascular risk after a clinician-patient risk assessment. There it is again. You've got to talk to your doctor. It's a partnership. Think about what's going on with you. If your cholesterol is high, don't let somebody just watch it be high. Deal with it. You can try with diet and exercise, but oftentimes a statin will be required. Many people tell me they can't take statins. A lot of the time that's probably not correct, but there now is a new drug. The first new drug just came out. Maybe Dr. Page will talk about it, that is a non-statin way to treat cholesterol. Diabetes is a very powerful risk equivalent for cardiovascular disease. Cardiovascular disease is the most common cause of death for men and women with diabetes, and I'm mostly talking about type 2, but unfortunately type 1 diabetes and type 2 diabetes are very likely to end in cardiovascular death. The risk for cardiovascular disease is 3 to 7-fold in women with diabetes versus 2 to 3-fold in men with diabetes. So for some reason, and we don't know why, diabetes and smoking again do appear to be worse risk factors for women than for men. The effects of diabetes on cardiovascular risk are really terrible, and they are, again, worse in women than in men. And these are data from the Framingham study, which Dr. Buttrick measured, which was just such a seminal study done in Framingham, Massachusetts. And for every risk factor, for every manifestation of heart disease, women do worse than men with diabetes. So for the guidelines say, and I have all the guidelines in red if you have not figured that out, because they're not my idea, they are verbatim guidelines from the American Heart Association. I'm very evidence-based, and I don't like to give recommendations based on my own opinion or anyone else's opinion, but this is American Heart, American College of Cardiology. So these are the guidelines that we most talk about and that we adhere to. For adults with type 2 diabetes, lifestyle changes such as improving dietary habits and achieving exercise recommendations are crucial. If medication is indicated, metformin is first-line therapy. It's the most commonly given diabetes drug, followed by consideration of other drugs, and there are lots of drugs for diabetes. Let's talk for a minute about obesity and nutritional recommendations. Normal weight is 24, a body mass index, and hopefully you've all heard of the term body mass index. It's kilograms per meter squared. It considers your height and your weight. And the last thing I quote here is not a guideline, it's a website, but all you have to do is go on the web and type in body mass index calculator, and you can figure out your body mass index quite easily. So we consider people who have a body mass index of 25 to almost 30 to be overweight, and obese is over 30 kilograms per meter squared. And this is a risk factor for cardiovascular disease. This is a cartoon from my colleague, Dr. Joanne Lindenfeld, who said, "My doctor told me to stop having intimate dinners for 4 unless there were 3 other people." And this is Orson Welles, the famous actor, and it's a sad truth. The portions that Americans eat are very large. If you go into a place, I don't want to name places because that seems kind of mean, but portions are often actually enough for 3 or 4 people. They're just really big. So a good strategy can be to put away half of it, or to eat half of it if you can resist, or a quarter of it depending on the size, bring the rest home. But people eat too much a lot of times. And as a result, in the United States, there's a rising tide of obesity and overweight across the country, which are on the top 3 maps of the United States. And Colorado is often touted as being the leanest state, and it still is, but if you look at the data, it shows that Colorado citizens are also getting heavier. We're still maybe better off than other states in the United States, but we're catching up, and that's not good news. And the obesity epidemic correlates with the diabetes epidemic as well. So there's more and more. Obesity and diabetes are very closely related, especially I'm talking about type 2, not type 1, which is more found in young people. But type 2 diabetes is actually now being found in young people as well. So diabetes and obesity becoming more and more of a problem even in Colorado. So what are the dietary recommendations? On the left side of this graph, you see the USDA, the United States Department of Agriculture pyramid. And on the right side, you see the Mediterranean pyramid. And I'm very struck that the Mediterranean diet is a very, very healthy diet. And very, we had it for dinner tonight, as a matter of fact, which I was delighted to see. And I think it's very healthy. It recommends more fruits and vegetables, meat a few times a month. Never recommends ice cream, but it does recommend some dairy, but I still eat ice cream occasionally. And it recommends very little red meat and no processed meat, virtually, because those things are not good for your health. I do believe in moderation. I think if you try to not eat something really hard, sometimes you end up eating more of it. So if you occasionally eat red meat, if you occasionally have ice cream or even whatever, French fries even, or potato chips, you should not have them often. They are not health foods. Lots of fruits and vegetables are recommended, but some moderation is probably a good idea. Healthy eating guidelines state that all adults should consume a healthy diet that emphasizes the intake of vegetables, fruits, nuts, whole grains, lean vegetable or animal protein, and fish, and that minimizes the intake of trans fats, red meat and processed red meats, refined carbohydrates, and sweetened beverages. For adults who are overweight, counseling and caloric restriction are recommended for achieving and maintaining weight loss. It is a big problem. It is hard to get people to lose weight. It is very hard in our society where big portions are so present, and it's a problem, though. And learning how to, I think recording what you eat can be very helpful in fighting off eating more. Because if you have to record it, as is habitual with Weight Watchers, or for free, you can do it on MyFitnessPal, I think those things really help. Okay, my favorite one, if I have a favorite risk factor, is physical inactivity. I'm not in favor of physical inactivity. I'm in favor of physical activity. Lack of exercise is a proven risk factor for heart disease, and it's a growing epidemic also in the United States. Most Americans are sedentary. Heart disease is twice as likely to develop in inactive people as those who are more active. Physical activity will not, I repeat, will not cause you to lose weight, because oftentimes people start eating more when they start exercising. They might be a little hungrier. But exercise will help you maintain weight loss. So if you're in a weight-losing mode and you exercise, it'll help you metabolically keep that weight off. And exercise also really improves diabetes and improves blood pressure. Women should exercise to increase their heart rates for 30 minutes a day, 5 times a week. And in fact, men should also aim to exercise 150 minutes a week. About 1 in 3 adults gets no leisure time activity. That means that they don't even get up and take a walk once a week. Nothing. Most people are very sedentary in this country. Colorado people tend to be a little more active. I always think it's partly because of the weather here, although not today. I'm not voting for today's weather, but our weather is often better. Among students in grades 9 through 12, where remember there's no mandatory physical activity classes, there are hardly any, only about 27% meet the American Heart Association recommendation of 60 minutes of exercise every day. Kids are supposed to get 300 minutes a week, and most kids are definitely not getting that. I mean, our society is against it, with all the screens and the phones and the TVs, kids are tending to be more sedentary, but they're supposed to exercise more than adults by an hour versus half an hour, and girls are more sedentary than boys. And this is the prevalence of meeting the 2008 Federal Physical Activity Guideline Committee that I was on and helped write these guidelines. And what you'll see is that men always tend to be more active than women, and white men more than black men, white women more than black women, but and Hispanics also much less physical activity, women less than men. And most people are not meeting the guidelines. And if you look, no matter how you cut it, people are not exercising enough. And if you're a minority, you're exercising, getting less exercise. And this is not good, of course. So the guidelines say from the Department of Health and Human Services that physical activity, you should be doing any amount of physical activity. Even, and they've just updated these guidelines this past year, you should be getting some physical activity, and anything is better than nothing. However, if you do 150 minutes a week, that's the recommended dose. As you go towards 300 minutes, it's even better. And you should also do something that's core or muscle strengthening twice a week in the gym, if you can. Or you can do it at home if you have weights at home. So you should be doing something like that. And the muscle strengthening bouts should only be about 20 minutes each time, or only have to be. You can do more, no one will stop you, but if you do this prescription, it will help your health for sure. The data incontrovertibly support that. And there are lots of ways to stay fit, there are lots of exercises that you can do, and you should really think about what's fun. I know for sure that if it's not fun, people are less likely to do it, right? I mean, everybody, why would you want to do something that's not fun? You wouldn't. For a lot of people, they may not realize this, but walking is an exercise. Walking counts as much as any exercise, especially if you're not walking a dog that stops at every lamppost, I will be honest. But your dog does need walks, so you might have to walk twice. But if you're walking with a friend, if you're walking with, a neighbor, family, it's so beneficial to both of you. I had a patient once who told me that one day she wanted to take a walk, but she didn't want to walk alone. So she called her grandson, who was 8 years old, and said, "Would you like to take a walk with Nana?" And he said, to her shock, he said, "Yes." So they started walking together, and that kept them both going in a good direction. But there's lots of things you can do that are exercise. And more the recommendations say anything you do, even if it's for a short period, helps you. It's just we want to try to get those 150 minutes a week. So that's the guideline. 150 minutes a week. Again, everything we find, and the lower bars show the effects on heart attack. I want to come back to summarize that women do worse than men with regard to having more heart attacks and dying more after their first heart attacks. Minorities, women of minority background, more than women who are white. So for everybody in this audience, men, women, and everybody, you all need to take care of your heart. It's really important. And you can take care of it. That's the really wonderful thing. You can have a beneficial effect. So to summarize very simply, heart disease is the #1 killer of women and men. Pay attention to your risk factors. Talk to your doctor. You are a partner with your doctor. Don't be afraid to say, but I understand that the leading cause of death in women is also heart disease. Don't be afraid to take up these questions with your doctor. It's your health, and you ultimately are responsible. So please be aware and have those partnering conversations. And remember about exercise, I have to say, walking shoes are $80, a triple bypass, 80 grand. It's probably more than that now. Think of all that cash in hand and march that tush along the land. Thank you.
All right, I have a mother who can still do the splits, and I need to send Judy the picture. My mother would be mortified, but I feel like I should send her it to add to this presentation. Our last and final speaker for tonight is Dr. Robert Page. I first met Dr. Page as part of our Women's Health Symposium. So if any of you are practitioners, you probably have seen and heard that we hold an annual Women's Health Symposium where we try to bring our women's health knowledge to those that treat patients. And he spoke for us, I think it was last year, this month, and both Nan Uday, my colleague, and I walked away saying we've got to get him to a Let's Talk. So thank you. Dr. Robert Page is a professor in the departments of clinical pharmacy and physical medicine and is the clinical pharmacy specialist for the Division of Cardiology, section of advanced heart failure and heart transplantation. Dr. Page has 25 years of clinical expertise in the management of patients with heart failure in both the outpatient and inpatient setting. In addition to being a board-certified pharmacotherapy specialist with added qualifications in cardiology and a board-certified geriatric pharmacist, he is also the clinical lead for the Colorado Evidence-Based Drug Utilization Program. He has published over 200 peer-review manuscripts, abstracts, and book chapters in the management of patients with cardiovascular disease. Welcome, Dr. Page.
Thank you so very much. That was, again, we got her. Anyway, as we're getting this set up, again, it is really an honor and a pleasure to be here. The one theme I want you to take away, and you've heard this from Drs. Regensteiner and Dr. Buttrick, is I'm hoping that this lecture series empowers you to ask questions about your heart health. I wish my mom had done that before she had a stroke. And I remember when I used to ask questions, she would go, I'd say, Robert, why are you doing that? Don't ask any questions. I'm like, Mom, what? You spend all this money getting me trained, and I'm going to ask questions. That's the one thing I would say. Always ask questions. And again, it's a partnership between you and your physician and your provider. And so that's the one thing I want to make sure that you take away is in terms of, and I'm hoping that you leave here thinking, yeah, I'm empowered. Gosh, y'all need to wake up. All right. I'll wake you up. All right, I have no disclosures. All righty. One of the things I do not do is do well behind a podium, but I am going to try this. All righty. Which of the following is true? And I want you just to, I'm going to read through them, and then I want you to raise your hands. Remember, there's no judgments here, okay? Women absorb medications from the stomach better than men, okay? Women get rid of medications quicker from the kidneys. Women metabolize medications differently than men. All of the above are true. Now, I want you to reflect on this. I'm going to make sure you're paying attention to me because I am the one who will call on you. All righty. This is going to be Pharmacology 101. I promise you, when you leave here tonight, you will know more than your physician. No pun, nothing, Dr. Buttrick. But I promise you, you will know more. So what I want to say really briefly is that there are differences between men and women, even when it comes to how your body breaks the medication down. Now, the one thing, the term, the sexy term that we use for this, and I would actually say you could use this at a dinner party one time to make yourself, it's called pharmacokinetics. What that means is how the body processes medications, how the medication is absorbed, how is it broken down, how is it eliminated from your body. And there are differences that exist between men and women. I'm going to bring up, this is an older drug, digoxin. Realize that when you take a tablet, it has to undergo what we call dissolution, meaning it breaks down into the liquid of your stomach. It gets under degradation, and it has to diffuse. It's got to get out of the muscle in order to make its way into the bloodstream. Again, once a drug is in solution, it can be absorbed, okay? And there are many different things that can affect that. That can be how fast your GI tract is moving, kind of like I had some really bad green chili last night, and my gut was a moving. So I know, anyway. Illegal Pete's, no green chili there. I'm going to warn you of that. Acid-base characteristics, okay, back from chemistry, in terms of the medication itself. The percentage of your body fat, how well your intestines are going to absorb it, and then also in terms of what spankic blood flow is the blood flow that's coming away from the intestine. Once a drug, though, goes through all of this, it then goes to your liver. Think of your liver as the true purifier, okay? And so we call this, and this is the sexy term for it, first pass metabolism. And that is where the drug is broken down into its active or inactive metabolites, and then it can make its way into the bloodstream. All righty. Are there differences between men and women? Well, I wouldn't be up here if there weren't, would they? All righty, so drug solution in terms of absorption. Believe it or not, men in the room absorb drugs much better than women, okay? That could have something to do with the gut lining, and there are a lot of things, but for the most part, men do absorb drug better. We also know that men, compared to women, have better absorption, not only from within the stomach, but from within the intestines. You absorb things not just in your stomach, but in the whole gut as a whole. And so that can be an issue. We also know, and again, I don't know if I agree 100% with this, but in terms of overall percentage of body fat across the spectrum, we find that women have a little bit higher body fat compared to men. Why does that matter? Remember, like dissolves like, and only drugs that are dissolved can be absorbed, okay? So if I have a fatty drug and I eat it with that beautiful thing like Dr. said of ice cream, then I'm going to get better absorption, okay? So again, if you have more body fat, the drug is more what we call lipophilic or fat-loving, it's going to make its way in very easily. The other, again, in terms of blood flow, the sphincteric blood flow, is men also have it better than women. The other aspect that comes into effect is that men clear drug faster than women. And it could be the fact that there's greater blood flow to the kidneys. Because remember, your drugs go out of two ways, the kidneys or out. You're not supposed to talk about going to the bathroom, but yes, through poop. Anyway, there you go. All righty, so. And also GI transit. And I have to say, I do believe this. Men versus women seem to have much faster GI transit. The one thing where my data, where my research will focuses in on is how drugs are metabolized. Now, I don't care that you know all this CYP, it stands for cytochrome P450, 3A4, and 2D6. These are the two major enzymes that metabolize 95% of the drugs on the market. 60% of those are through 3A4. Okay? And you'll notice here that women have a greater predominance of this one enzyme compared to men. All right? Now, if you have a drug that depends on metabolism to be, like in terms of an active metabolite, that might be a good thing, but if you have too much, it can cause a bad thing in terms of side effects. Okay? 2D6 is more common in men than it is in women. Now, a whole new science that is emerging is this thing called pharmacogenomics, in which we're learning that it is, as Dr. Buttrick mentioned, it gets down to your genes. And it may not just be male and female, it may be more of a genetic issue. And we're still teasing that out. So, which of the following are true? All right, you got to raise your hand. All right, women absorb medications better than men. All right, good, you're listening to me. Women eliminate medications quicker from the kidneys. You got it. Women metabolize medications differently than men. There you go. You rock. 100%. You get A+ on pharmacology for tonight. All righty, and that is really true. But you know, the one thing is, and Dr. Buttrick highlighted this as well, that we have not been studying women very well, particularly when it comes to medication or clinical trials. And so we're still figuring some of this out now, even today, in 2020. All righty, I know this is a big, huge list of drugs, but does these changes in how your body absorbs, metabolizes, and eliminates medication, does that translate to an effect? Okay, we're going to focus in on women. Alcohol, all righty? There may be a difference why if you only have half of a glass of wine compared to your male colleague who can have like 2 or 3, you don't get as buzzed. Or you may get buzzed quicker. Well, the reason is that women have a lower amount of certain enzymes that metabolize alcohol. So you have more parent alcohol in your system. Antidepressants. We find that in general, that the selective reuptake inhibitors, the SSRIs that are commonly used, as well as the tricyclic antidepressants like amitriptyline. These medications, we find that they have higher blood concentrations in women. They tend to absorb much better. This is dependent really more so upon the acid-base aspect of the drugs. But again, we're talking about heart health. Aspirin. We find that women actually have a slower elimination of aspirin from the body. We heard already from Dr. Buttrick that beta blockers are drugs such as metoprolol tartrate, metoprolol succinate, atenolol, propranolol. These are drugs that are used not only, we talked about it with heart failure, but primarily they're also used in things like hypertension and post-heart attack. And what we find is that women actually need lower doses because they absorb these drugs much, much better. The other one I want to focus in on statins. Alrighty, how many of you have heard, how many of you have heard, statins are bad, they're just bad. I get that all the time. Yes. I'm going to tell you statins are good. They are really good, especially if you've had a heart attack, by the way, because it does reduce your risk of having another, even in both men and women, and this has been shown, by at least 30-35%. So I have to say that statins are good. And what we find is that statins, for certain ones, the ones that are the fat-soluble ones, the ones that that are what we call lipophilic, they basically will have higher blood concentrations. This is the simvastatins or the Zocors or the Mevacors or the Lovastatins or the atorvastatins, which is Lipitor. And then also with regards to warfarin, that is a blood thinner. And also these new sexy drugs that you'll see on the market, the Eliquis and all of those as well. All of those brand new drugs, we find that women tend to have higher blood levels. And the reason is because it has something to do with the protein in your blood, your albumin, that typically women may have a little bit lower albumin. So they have more free drug floating around. Alrighty, so here's another question I want you to think. Women have a different side effect profile to certain medications compared to men. Remember, and I love this, and I'm going to use this, Dr. Buttrick, women are not little men. Anyway, I completely agree with that. So this is a true or false. Okay, I want you to think about it. Alrighty. There is, because of the pharmacokinetics, it translates, here's the other fun term I want you to repeat 10 times, pharmacodynamics. And that is the response that the drug has. And in particularly, adverse side effects fall into this. What we find is that women have a higher propensity to certain side effects of certain medications. One of those is an ACE inhibitor. Those drugs are drugs like lisinopril, enalapril, and ramipril. These drugs reduce the risk of death anywhere between 18 to 50% if you have congestive heart failure. They also statistically significantly reduce blood pressure and also the risk of stroke. But unfortunately, and I have to say at one point in time I was on an ACE inhibitor, the bad side effect is cough. And have any of you taken this medication before? Yeah. Did you get a dry, hacky cough that caused you to want to get up in the middle of the night and go, oh my God, I'm going to. I mean, I had one patient who said that he was going to divorce his wife because of his cough, or her cough. But we find that women have a higher propensity to this side effect. And it may be related, as we heard from Drs. Regensteiner and as well as Dr. Buttrick, because of the biology. That you may produce more of this enzyme, this angiotensin converting enzyme, that then when you block that, that creates a little bit more of this other substance called bradykinin that leads to you to cough. So the other is antiarrhythmic. These are drugs that are used to control heart rate and heart rhythm. All right, some drugs that we use for things like atrial fibrillation, ventricular tachycardia, those type of things, okay? We heard from Dr. Buttrick that women have a higher propensity for this, what we call QT prolongation. That means that there's a prolongation in terms of the conduction potential that can lead to potentially a fatal arrhythmia. And women, when we add medications that prolong this, they are at higher risk. And so we keep a closer eye on that. Okay, we've with the anticoagulants. These are the blood thinners. These are the Eliquis, as well as the warfarins or the Coumadins of the world. These anticoagulants, we find that there is a higher risk of bleeding. That from a biologic perspective, women tend to have a higher, what we call international normalized ratio, and also have much higher bleeding major bleeding events compared to men. Same thing when it comes to the antiplatelets like aspirin. And as Dr. Buttrick mentioned, right now we're like, nah, aspirin. But if you had asked us 10 years ago, we love aspirin, but not anymore. But nonetheless, women have a higher tendency for bleeding, which means they may need a much lower dose. In terms of the cholesterol medications, the statin medications, particularly the ones that are fat soluble, what that correlates to, I find, is an increased risk for adverse events related to muscle. Because the drug is fat soluble, it moves into a large amount of tissue, in particularly the muscles. So women tend to have a statistically significant higher risk of what we call muscle aches, or the official term, myopathy. But I always have this conversation with every one of our patients that are on a statin, is that the benefits outweigh the risks. I would much rather you have a little bit of muscle pain compared to being 6 feet under. Anyway. All righty, ba-bum-bum. All right, the last one is a set of diabetes medications. Again, Dr. Regensteiner, this is her area of research. There is one particular class that we don't use as much anymore. They're called the thiazolidinediones. I want you to say that 10 times. Thiazolidinediones, I'm just kidding. They are, what we find is this class of drug, and these are things such as rosiglitazone and pioglitazone. They basically killed your liver, way back when, and then we realized from about 20 years ago that was the issue, and then they kind of fell off our radar, and now we realize that's not the case, and now we're using them again. But we know that women are 2 times more likely to develop a fracture if they've been on this for a long period of time. So, have I convinced you? Women may have a different side effect profile to certain medications than men. How many of you say true? Yes, pay attention. Excellent. Awesome. Perfect. All righty. Boop. True. Oh, double. The other thing I want to highlight is that this does correlate to outcomes. And again, my niche is primarily advanced heart failure and heart transplant. And Dr. Buttrick mentioned this as well within his section, is with regards to heart failure in women. One of the things I think we've done a big disservice with, number one, is not enrolling women in heart failure trials. But also, number two, is not focusing in upon, we have like 40 years of phenomenal data if you have a low ejection fraction, meaning the percentage of blood that is ejected from the heart. That's the cutoff for that definition is 40%. If you have another type of heart failure where the heart can't really relax, it's called heart failure with preserved ejection fraction. And these are typically patients with an ejection fraction greater than 50%. So they have signs and symptoms of heart failure, but they still have this elevated ejection fraction. The problem is we've got great data with this if you have a low EF. If you have a very high EF, the unfortunate thing is there are absolutely no drugs out on the market, with the exception of what I'm just going to talk about in a second, that can reduce your risk of death. That's insane. I mean, that's just, and the thing about it is that form, that heart failure with preserved ejection fraction is much higher in women, particularly older women. So there is a high likelihood that as you get older, you may develop this. And the unfortunate thing is the only thing we can recommend is control your blood pressure. We can control the fluid that gets into your lungs or in your legs, and we keep your diabetes and other comorbidities under control. But we don't have any drugs. But we do have some recent data that was published looking at a drug called spironolactone. This study was called the TopCat trial, and it had a predominance of women, and because they are the ones who have this type of heart failure. Now, I know this looks really, really confusing, but what I want to show you is, in this trial, if you looked at everybody, and it was an international study, everyone across the board did not, theoretically, they didn't benefit. But when you get to the devil in the details, what's interesting is, and the red lines represent women, the dotted line represents if you got the sugar pill or placebo. And then again, blue is males. Who did better? Who actually had a 37% reduction in mortality? Women with this drug, spironolactone. Now, everyone benefited in terms of hospitalization, but in terms of mortality, this is what I'm going to add on from Dr. Buttrick's lecture, is the fact that we need to start thinking about differences between men and women in responses to medication. And this is one of them. This is so nerdy of me. I got excited when I saw these data. I'm like, yes, we have something to treat this. So, and we're still trying to tease this out, and we really don't understand. And I'll show you, it can be completely different. And both Dr. Regensteiner and Dr. Buttrick mentioned this. Women compared to men have a different biology. The heart is genetically different between men and women, okay? There's a difference between emotional stress. There's differences in terms of the comorbidities and chronic disease states as well, like breast cancer, for example. There are many drugs that with breast cancer, I call them the nibs and the nabs. Some of them, as a pharmacist, I can't even say. But we know that they can lead to cardiomyopathy or heart failure. We know that women tend to have, as we heard already, stiff blood vessels and also have a higher systemic inflammatory response, okay, compared to men. All right? Men tend to be obese, have greater incidence of obesity compared to women. Okay? So again, there's a lot of things. This is what we call phenotypes on how patients present. Okay? There's differences. And one aspect of that deals with men versus women. The other thing I want to highlight is this aspirin issue. Right now, again, before you ever, I completely agree with the Bayer Medicine commercial. Before you start any aspirin regimen, you should consult with your primary care provider. But for the most part, women benefit different than men. In particularly when we look at primary prevention, and as Dr. Buttrick mentioned as well, this primary prevention, the guidelines keep changing every 2 to 3 years based upon the data that come out. And right now, we're not a big fan of primary prevention. If you've had a heart attack or a stroke, completely different story. But what we find is, and this is, I want you to look at that line. See that line? If anything on the vertical, if in terms of the horizontal, if anything crosses that, the vertical and the horizontal cross, that means there's no difference, okay? The big squares, okay, if it falls on the side that's less than 1, that's a very good thing. Anything greater is a bad thing. Greater than 1 is bad. So when you look at this visually, women actually tend to they do better with aspirin in terms of a reduction in ischemic stroke. And while men, on the other hand, don't really benefit as much from that aspect, but they tend to benefit more towards a reduction in heart attack. Okay? Now, that has a lot to do with both biological factors, but also, as we've talked about, it has a lot to do with some of the pharmacokinetic aspects and the pharmacodynamic aspects that women exhibit to aspirin. So there are many knowledge gaps. I have to say, this aspect of gender with regard, or male versus female, when it comes to pharmacotherapy, which means just medications, we're still teasing it out. It's still coming to the forefront. This is not something and there are many knowledge gaps, which is what I'm going to highlight, and then there also leads to ramifications. It is very sad that women have been excluded from many clinical trials. And the problem is particularly younger women from the standpoint that some drugs are teratogenic. That is meaning it can hurt the fetus. And so that's why a lot of women were excluded, and particularly younger women, in some of the early heart failure trials, because they're like, well, we don't want to put a woman who is potentially fertile at risk. And nonetheless, now we're realizing, gosh, we really need to have some of these data and that they benefit just as well as men. The other is there is still a limited understanding of the pathophysiology for certain conditions that have a gender predominance. And we're starting to tease this out. Both my colleagues have already kind of highlighted that within their talks already. I do believe there is a lack of understanding and appreciation for sex-specific risk factors. And Dr. Regensteiner did a phenomenal, very elegant job of explaining those to you. And I think that this is still something, even to this day, that we are still trying to figure out. And then finally, I believe there is a lack of guidelines and data on optimal medications and dosage for women. In some cases, this is not taught in medical school. And it's, if it wasn't for me, it probably wouldn't be taught in pharmacy school either. So again, we're really starting to expand our education with regards to this, but unfortunately this can lead to some serious ramifications. Number one is a higher rate of medication side effects, and some of these can be very bad, such as that QT prolongation I talked about. That could be fatal, okay? Or bleeding when it comes to blood thinners or antiplatelet agents. I mean, again, that's something that we monitor as pharmacists very closely. You could have suboptimal risk factor management in primary prevention. And really, in my mind, if we're going to get ahead of this thing, this aspect of cardiovascular mortality, this tsunami, it's going to have to be in primary prevention. And then finally, I believe all of this can lead to a lower quality of life in women because it's not being recognized. So one of the things that I want you to take home is the number one, and you've heard this throughout, is that women are underrepresented within clinical trials. And they comprise only about 33% of study patients, and that's, if not lower, and that's really sad. The other is, I hope I have convinced you that there are pharmacokinetic as well as pharmacodynamic differences between medications, their side effects, and how men and women respond. They are different. But unfortunately, we don't have a lot of clinical trials, and this is something that we're still exploring. And again, we need to have more pharmacologic studies. I would encourage you, honestly, to consider being in a pharmacologic trial and participating. And then finally, hopefully that this session has really empowered you to not only understand your risk factors, but to know your medications. I would find that 4 out of 10 patients that I talk to on a daily basis sometimes have no clue what meds they're taking. So they don't understand some of these side effects and things that can happen. I would encourage you to ask questions and be proactive with your primary care providers and your physicians, and ask the questions in order to get them answered. And with that said, I'd like to thank Dr. Regensteiner, the Centers for Women's Health. It's always been such a pleasure in order to get to speak to everybody tonight on this very cold Chicago night. Ugh. Anyway, with that said, thank you very much.
Doctors always give her like a ton of they give her the same medication that they would give, dosage, as far as my father, who is probably, 200 and something pounds, and she's 85 pounds. I mean,
so one of you bring up a good point. So the question was, there are differences within weight. The drugs that come immediately to mind, and you bring up a good point. As older adults, the average number of medications is 10. And so the one thing that I want to highlight too is, and that's over-the-counter and herbal and prescription, is that when you cross the threshold of more than 10, you have 100% interaction, chance for an interaction. In fact, I have to say this one thing. I was watching something last night on Johnny Cash. Do you know that Johnny Cash at his death was taking 45 different prescription medications? I fell on the floor. I said, what? Is that the case?
Several non-prescription medications.
Yeah, there probably was, true, I know. But to answer your question is absolutely yes. When I think of some of the blood thinners, particularly these newer drugs that you see like the Eliquis, those, we've started to pay very close attention to weight. And in terms of the dosing guidelines, they may need, they actually recommend a lower dose, particularly with women and also based upon your weight. And so the one thing I would encourage you is that when you're going in with your parents is to actually say, hey, is that the right dose for someone who's a very, thin person and ask that. And you know what? If you ask it, they may say, well, you know what? I never thought of that. Maybe that is. And so that's the one thing. But you bring up a point. Absolutely true. Certain blood pressure medicines, the one that Dr. Buttrick talked about, carvedilol, that will require a higher dose if you're greater than 85 kgs. And so we use a much higher dose. But again, that's one of the only types of medications, beta blockers, that have been studied in terms of weight. So absolutely. And I would ask that question. Mm-hmm.
In treating AFib for someone in their 70s, 80s, would you treat them indefinitely with anticoagulants?
With Eliquis,
Anticoagulants,
anticoagulants,
indefinitely?
well, I'll let you do that, but the answer is yes.
Yes and no. When we use anticoagulants to treat patients with AFib, it's always a risk-benefit balance. And we have equations that calculate stroke risk. You're trying to prevent stroke. We also have strategies to calculate bleeding risk. So there are people who are at risk for bleeding, people who are frail, who fall, and one tries to balance risk and benefits. So usually when I do this, I have a conversation with patients and say, well, your risk of stroke is 5% per year. Your risk of bleeding is 0.25% per year. That's a pretty simple conversation. When those numbers reverse, when the risk of stroke is 3% per year and the risk of bleeding is 5 or 6% per year, then you want to ask patients, how do you feel about that? And some patients will say, I'm happy to take the bleeding risk because I sure as heck don't want to have a stroke. And other patients will say, I'm not going to take a drug that puts me at risk of bleeding. So it's not a completely straightforward answer.
Okay, how about post-stroke?
Pardon me?
How about post-stroke?
After somebody's had a stroke, one of the factors that we use to calculate stroke risk is whether you've had a prior stroke. So if that's the case, then the risk of subsequent stroke goes up. And it's one of the elements that you factor into calculating subsequent stroke risk. Why don't we go to this side of the room, ma'am?
If you have multiple doctors prescribing multiple medications, multiple doctors prescribing multiple medications, maybe you're on 15 or more, who's responsible for checking interactions?
So one of the things, it should be I've trained about 90% of the pharmacists in this state. So I would say absolutely it should be your pharmacist. The one thing is I know we do a lot of pharmacy shopping to find the lowest cost of drugs. But when you only have one pharmacy that has one list of medications, it makes it so much easier. The other thing that I recommend is when you are taking more than 10 or more medications, you need to keep that list on your person. And have that, and also update that with with each provider that you see, so they have an updated list. And when you have questions like that, I would ask you to ask your pharmacist. I'm worried, and in fact, your question is very valid. When we look at surveys of patients, outpatients, or ambulatory patients, the number one question and fear that patients have is drug-drug interactions. And so that is the one thing. And you know what? I know, as I said, that these students have had, or not students, these pharmacists have had it because I've taught them. But I definitely would use one pharmacy, ask your pharmacist, and then keep a list of meds on you and always update it with each provider visit. And that will help. What about the PCP? No, with each provider that you see. Oh, your PCP should have everything. Your PCP is really your primary care doctor is your gatekeeper, per se. So.
Do you recommend a wine as part of the Mediterranean diet to help your heart?
I'm sorry? Actually, people say yes. Some people say a glass of wine, 1 glass, 5 ounces per woman per day is not a bad thing, and 2 glasses for men. So the dose is different for women and men. mostly people worry about people becoming alcoholics. So the tendency is to recommend against alcohol, but there are those who promote the Mediterranean diet and say glass is good.
And to chime in on that, the reason 1 glass versus 2 in men and women is because you have less alcohol dehydrogenase. See, now you know why. There you go.
I'll tell you a funny story. So a few years ago, a study came out which talked about the benefits of wine. And actually, when you read the footnotes, the amount of wine that was consumed by the subjects was remarkably high. So I shared this piece of information with a colleague. And then I got a call late one Friday night on the phone, and he said, "You're my cardiologist. I want to ask you a question. Should I open the 3rd bottle?"
Where do I? You can just talk. Okay. What are your thoughts on women getting heart scans?
So the test that is being referred to is a relatively straightforward test called a coronary calcium score. It's a study that can be done very, very quickly without even taking off your clothing. The data readout is the amount of calcium that's deposited in your coronary arteries. The data from this study, these studies, I think have been to some degree sensationalized. So people will come to me or to a doctor and say, "A heart scan, and I've got a 90% blockage," because the test documented the presence of significant calcification in a particular coronary artery. And that's actually not accurate. What the test does do is it defines to some degree cardiac risk. If you're in the top quintile of coronary calcium, then you have a higher cardiac risk than somebody who's in the 2nd quintile. So in a way, it's a relatively easy way to ratchet up your own concern about your health, but it doesn't necessarily mandate further testing. If the coronary calcium score is high, it mandates very focused attention on risk factor modification, as Judy spoke about.
Those little cards in the mail about all, 5 tests or whatever they are, and that kind of thing. What are your thoughts on getting
On what
those
tests?
done?
I'm sorry.
Like your carotid artery and all the various tests.
There are health fairs that will provide a variety of different screening tests, and I think it's probably useful data to have. One can calculate vascular age by looking at carotid stiffness, and one can certainly, as I said, use coronary calcium to get some information about 10-year and 5-year cardiac risk. But I think if you get these tests done at a health fair and they're abnormal, it's probably worthwhile talking to a physician, a cardiologist, and have him or her sort through what's real and of concern and what's not. We talked a little bit about cholesterol. I think knowing your cholesterol is a good thing. Knowing your blood pressure is a good thing, because those are things that one can modify relatively easily. Sure.
I came expressly to see if you were going to address the issue which you did mention about breast cancer and the chemicals that are now recommended that we take for 5 to 10 years following an estrogen-driven breast cancer diagnosis. And they really are, it's a flip the coin. Do you want heart disease or do you want to get cancer again? Particularly in those of us with menopause who are short on estrogen anyhow, which encourages heart disease and coronary issues on top of it. So I'm understanding that a lot of oncologists never test for your estrogen level before you are prescribed an estrogen blocker in the first place. And once you've been on an estrogen blocker for a while, then you have to go off of it for a while to see how much natural estrogen you have and whether that's going to affect every organ in your body, including your heart. It's a real tug of war, push-pull. What's the current thought on that? I was glad you mentioned it. That's why I came.
So I think we've entered a really interesting new era in cancer therapy. We have, I will say the oncologists have made remarkable advances in treating diseases that heretofore were untreatable. And it's very exciting to be at that threshold. What we haven't learned are what are the long-term toxicities of some of these medications. And I think, I have to say it's a work in progress. I'm delighted to work with my oncology colleagues because I have patients and actually colleagues who would have been dead years ago had they not been able to take advantage of newer targeted chemotherapy and chemotherapeutic agents that are specifically targeted to subsets of breast cancer, lung cancer, and so forth. But you're absolutely right. We've opened to some degree a Pandora's box of long-term toxicities. I think at the moment, I think that the benefits of most of these chemotherapeutic agents far outweigh the potential toxicities, and that we're learning how to mitigate the toxicities, how to manage the toxicities, but we haven't learned everything yet because the class of drugs that you're talking about and a variety of other drugs are really pretty new on the market. And in fact, there's an entire field of cardio-oncology which is exploding to try to manage and to anticipate and to treat unanticipated toxicities. But I don't want to leave you with a message that these drugs are something to avoid. Some of them are truly miraculous. And the 5-year cure rates for diseases that previously were untreatable this has now become the rule rather than the exception for many solid tumors. I don't know if that exactly addresses your question. It's a complicated one.
It helps. I understand these drugs are new, relatively speaking, and we don't know all the answers, and certainly the success rate now is far better than ever before. And also our level of knowledge as patients is far greater than it ever has been. So we all are out there reading everybody's opinions and ideas and responses, but it's good to hear it from the experts. Thank you very much.
Institution better than others. There's a member of my faculty who works very closely with the oncology group, and she tries to see ahead of time the group of patients who are anticipated to be at risk and then to follow them subsequently. But we are in a learning curve phase.
Are there trials going on with that?
Oh, yes.
Of course.
Yes. And we're also, a lot of the drugs where cardiac toxicities are being identified, they're being, the element, the component of the drug that seems to be credible for the cardiotoxicity is being modified in order to minimize risk and optimize benefit. But as I say, we're in a very labile period of discovery.
So stay tuned.
Yeah.
And a lot of these drugs have been, as Dr. Buttrick mentioned, have been fast-tracked because of the mortality benefit. So the FDA wants to get them on the market as quickly as possible. But the problem is we don't know what some of the side effects are going to be. So if you are receiving one of these medications, one of the things that's so very important is to report to your physician any side effects, because usually if they can catch it early enough, then maybe we can prevent it from happening. I mean, we were one of the first sites to document heart failure-induced trastuzumab. That was here at this university, and because of what got reported, it ended up making its way, into the FDA and this and that. So being vocal and empowered and making sure that you're communicating, I'm really serious. So that's like one of the key things. These drugs are awesome, but sometimes we don't know all the side effects.
We have a question. Go
On the tails of what she just asked, I'm interested, over here, sorry. I'm interested to learn 18 years out of breast cancer, chemotherapy, radiation. Adriamycin Cytoxin has my attention because I was fairly young when I had it. And is there current data, I'd love to hear that, about the effects of the muscle walls of the heart and what I should be looking forward to. I mean, I've had heart tests, I do a stress test, that kind of thing.
Adriamycin is a known cardiotoxic agent. The cardiotoxicity is both idiopathic and dose-related. So oncologists tend to try to keep the dose below and it's a cumulative dose. If you're 18 years out and your heart is actually fine, probably it's not relevant and you have survived and the dose was adjusted appropriately. Radiation is another confounder, and there are long-term toxicities that can accrue as a result of mantle or mediastinal radiation. But again, if you're 18 years out, I think you're probably good. Yeah.
In regards to inflammation, are there blood tests that will indicate the amount of inflammation that you have within your body and the impact that it will have on your heart health?
So inflammation is currently a very hot topic in the cardiovascular world. And we do have blood tests that can monitor sort of background inflammation, C-reactive protein, sedimentation rate. There are a variety of other markers. The area has become of great excitement lately because of a trial that was published just a couple of years ago, which looked at the use of, it's an IL-1 beta blocking antibody. That's one of the key elements in one of the inflammation pathways. And the question that was asked by the investigator is, if you take this targeted anti-inflammatory therapy, what happens to your cardiovascular risk? And in fact, cardiovascular risk was reduced by a very sizable and to me quite surprising amount. So this has become an area of very active investigation. I'm not sure that the conventional tests that we use, C-reactive protein sedimentation rate, are sufficiently nuanced to identify the inflammatory pathways that might be contributing to cardiovascular disease. But you're right to ask, because the profession is all aflutter about targeting inflammation as a non-traditional strategy for cardiac risk modification. Study was called the CANTOS trial.